Hello, everybody. Ohio. This is a continuation of my talk and mini presentation just a few moments or few minutes before about the liver-lung link in clinical practice and how can the two organs, the liver and lung, be related in different diseases. And I already talked about the categories of hepatopulmonary relationship or the categories of hepatopulmonary involvement in clinical practice. And here I just want to continue talking about this issue, mentioning that the clinical presentation is simply a patient with liver disease coming complaining of shortness of breath or difficulty breathing. This is the commonest presentation. It's difficulty in breathing or dyspnea. So dyspnea is a symptom or presenting symptom of lung involvement complicating liver disease. Of course, in patients with lung disease complicated by liver disease, the symptoms might be right upper abdominal pain, right hypochondrial pain, or maybe hepatomegaly with abdominal swelling, or maybe in advanced cases even with ascites, that is abdominal enlargement or generalized abdominal swelling or distension, and or other local and general features. As regards the chronic liver disease patients who present with respiratory symptoms, they are more commonly lower respiratory symptoms in the form of, and commonest lower respiratory symptom in patients with chronic liver disease is shortness of breath or difficulty breathing. And here the liver specialist should refer or should coordinate with a lung specialist or a pulmonologist to put the patient on the proper plan. We should work always together, internal medicine with other disciplines in order, or what we call multidisciplinary approach, in order to give the best clinical decision and the best clinical management. So shortness of breathing is a common manifestation. So also there might be other manifestations or respiratory symptoms like cough, dry or with sputum, like even hemoptysis, patients with tuberculosis involving both the lung and the liver. There might be cough and sputum in pneumonias involving the lung and the liver. There might be also chest pain or chest discomfort in some clinical syndromes involving the lung and the liver, but the most common is shortness of breathing in patients with chronic liver disease, and here we have to search for possible pulmonary involvement in patients with diagnosed or in a known case of a chronic liver disease. And as I mentioned, the most common form of chronic liver disease is chronic hepatic disease or chronic hepatitis with or without cirrhosis, which might be compensated or decompensated later on, that advanced and progressed into chronic hepatocellular failure with even in some cases acute exacerbations or acute on chronic hepatic encephalopathy. So this is the how does a patient with chronic liver disease and lung involvement present clinically with shortness of breathing or dyspnea. Here we start to search for possible pulmonary involvement. And this can happen, for example, in acute liver disease with lung complication. The most common example is in acute hepatic failure or fulminant hepatic failure complicated by adult respiratory distress syndrome, and the patient will present with acute dyspnea. And here there is non-cardiogenic pulmonary edema involved in complicating acute hepatic failure in patients with massive or fulminant hepatitis, for example, whether alcoholic or viral hepatitis, with fulminant hepatitis and then fulminant hepatic failure, or maybe related to drugs like alcohols, like toxins, or maybe in some hereditary disorders, also complicated by acute hepatitis and fulminant hepatic failure. And the patient might get as one of the complications of systemic complications of fulminant hepatic failure is adult respiratory distress syndrome or ARDS or non-cardiogenic pulmonary edema, and this presents with acute dyspnea acute dyspnea, and this is of course life-threatening complications of acute hepatic failure. In patients with chronic liver disease, on the other hand, they also might present with assurance of breathing, and here we have to look for one of two important if there is no direct involvement of the interstitium or the parenchyma by interstitial lung disease, for example, as I mentioned before, in patients with autoimmune liver disease, interstitial lung disease. And sometimes also pulmonary hypertension, that is pulmonary vascular involvement in patients with chronic liver disease. And also maybe pleural involvement in patients with chronic liver disease, or maybe mediastinal involvement in patients with chronic liver disease. So these are different anatomical categories which might complicate chronic liver disease and present with dyspnea, shortness of breathing, involvement of the lung parenchyma, involvement of the vasculature of the lung, involvement of the pleura, that is the pleural space surrounding the lungs, involvement of the mediastinum itself between the lungs, secondary to liver disease. So this might all or in part cause or may share in the pathogenesis of dyspnea. Why is the patient dyspneic? Is it lung? Is it lung parenchyma? It is lung vascular? It is pulmonary vascular? Is it pleural? Is it mediastinal? Is it what exactly? Here, this is the role of the physician to reach to how is the chest involved in patients with chronic liver disease. And two important categories here I want to mention is the hepatopulmonary syndrome and then the portopulmonary hypertension. Let's talk about what's the differences between these two clinical categories. About the hepatopulmonary syndrome, in short, it is a triad of low oxygen saturation, arterial low oxygen saturation, the arterial blood, and this we can detect it by arterial blood gas analysis. So there is hypoxemia, and at the same time there is what we call intrapulmonary vascular dilatation. So the pulmonary vessels are enlarged and dilated in the setting of a patient with known liver disease or portal hypertension, or maybe congenital portosystemic shunts, what we call congenital portosystemic shunts. So if a patient is known to have chronic liver disease or portal hypertension due to any cause, primary or secondary, or patient with congenital portosystemic shunts, and then this patient gets hypoxia and there is pulmonary vascular dilatations, this is the triad of portopulmonary syndrome. And the patient usually presents with breathing, especially in the sitting or standing position, and that's breathing difficulty when he stand up or sit down, and this breathing is down when he lies flat in bed. Also there might be plewish discoloration of the fingers and lips. That is cyanosis. There might be central cyanosis. Also, there is clapping of the fingers and toes. So digital clapping is a feature also. And there is intrapulmonary vascular dilatations, which are detected by what we call contrast echocardiography. So we need for diagnosis an arterial blood gas analysis to detect the hypoxemia, and the contrast echocardiography to detect the intrapulmonary vascular dilatations, which is a characteristic or one of the triad of hepatopulmonary syndrome. So it is a pulmonary features complicating chronic liver disease. That's why it's called hepatopulmonary. And what's in the lung shortly, it is intrapulmonary vascular dilatations. That is enlargement of the pulmonary vessels with low oxygen saturation, which present with shortness of breathing, especially when the patient stands or sit down, and becomes better when the patient lies down. Also, the hypoxemia increases when the patient stands up or sit down, and the hypoxemia improves when the patient lies down. And how can we detect the hypoxemia? By APG or arterial blood gas analysis. So this is the hepatopulmonary syndrome in short. And then the other category is the portopulmonary hypertension. The portopulmonary hypertension, it is a pulmonary hypertension that is vasoconstriction of the pulmonary arterioles and the capillaries complicating portal hypertension. That's why we say portopulmonary hypertension. So here the pathology is in the pulmonary vessels, and the pathology here is not widening and dilatation like in hepatopulmonary syndrome. It is vasoconstriction. There is vasoconstriction. There is pulmonary vasoconstriction. And this can be detected, of course, first by echocardiography, and then proceeding to cardiac catheterization to measure the right ventricular pressure, and then the pressure inside the pulmonary artery, or what we call the pulmonary arterial pressure and the pulmonary capillary wedge pressure, to diagnose pulmonary hypertension. So here there is pulmonary hypertension, which is diagnosed by cardiac catheterization. First echocardiography and then cardiac catheterization to measure the pulmonary capillary wedge pressure and pulmonary arterial pressure to diagnose pulmonary hypertension. And the cause of pulmonary hypertension is pulmonary vasoconstriction. There is pulmonary vasoconstriction causing pulmonary hypertension. And this is a complication or a result of portal hypertension and chronic liver disease. Because as we know, chronic liver can cause a form of portal hypertension. We call it sinusoidal portal hypertension, because as we know, portal hypertension might be pre-sinusoidal, sinusoidal, or post-sinusoidal. Here, in most of the cases, especially in cirrhosis, it is sinusoidal portal hypertension, and this is the commonest form of chronic liver disease, causing commonest form of portal hypertension. And it might be complicated by, as I mentioned, portopulmonary hypertension. The treatment of both conditions, hepatopulmonary syndrome or portopulmonary hypertension, is rather difficult, but the most definitive is liver transplantation. Although we have to select the cases who are right candidates for liver transplant, because liver transplant is not always successful in management of such cases. The condition may remain the same or may even deteriorate after transplant. That is why the selection of the proper cases candidate for transplantation is very important to treat whether the hepatopulmonary syndrome or the portopulmonary hypertension, which is a very common, or rather advanced common complication in the course of patients with chronic liver disease, especially cirrhotic patients with terminal disease. So this is in short the difference between the hepatopulmonary syndrome and portopulmonary hypertension. What we can do is just supportive treatment in most of the cases to improve the hypoxia in patients with the hepatopulmonary syndrome, or to lower the portal blood pressure and the pulmonary blood pressure in patients with portopulmonary hypertension by some medications, and most of them are rather experimental, and the success rate is not that high, and they are not suitable for every patient or all patients, but we must try them to alleviate the condition of the patients and for symptomatic relief in such cases. But the definitive, as I mentioned, is liver transplant to improve the pulmonary symptom. This is as regards the continuation or the second presentation as a continuation of my first presentation about the lung-liver relationship or hepatopulmonary relationship. Thank you so much and have a nice day.